clinical marker that we can use.
Which is a shame because it's such a cheap and very easy to perform assay. But either way, I don't think you need it to monitor. I think clinical endpoints is a more important thing.
Hi, I'm Trinh Nguyen from Vietnam. Firstly, thank you for the presentation, and I'm really interested in the question here because though also the question we have to face when we meet any patient with organophosphate poisoning, and the way we do the atropine in Vietnam is rather different. We got very severe patient with organophosphate poisoning with the cholinergic syndrome, and the way we do with atropines E, we do not use an atropine infusion anymore. Now we ask ourselves what is the first dose of atropine, how long we have to repeat the atropine, and when to stop it. And for the first question, we can bolus 2 to 5 milligrams. Anyway, I don't care. We can push the patient until the patient got the atropinization, and when the cholinergic syndrome is gone. So I don't care about the first dose, it's easy. So what about second dose and when we do that? We consider the patient we have an atropine score, and in that we set up the score that the patient got appropriate the heart rate and without the bronchos excretion and bronchospasm. And if the patient got the appropriate atropine score, and we watch the patient, and for example, the patient is stable for 2 hours, that means the dose we bolus that can keep the patient stable for 2 hours, and we give the same dose after 2 hours. That's the way we do. And for after 1 day, we calculate the total dose of atropine, and of course you will see that the next day the atropine dose will decrease and not as high as the first day. And when we watch a patient, we can find out what dose it can keep the patient stable, and that's the way we do. And we did a research in 2003, and we found out that if we give the patient less than 2 milligrams atropine a day, the cholinergic syndrome will not appear again. So we will stop atropine when the atropine dose for a day is less than 2 milligrams. Thank you.
Thank you. Thank you. We have time for one more question.
I have Sean from Atlanta. The clothes that they come in, the patients who are exposed to, it's a fairly common question to the SPY, who sometimes has to resort to asking the toxicologist on call, whether it be the fellow or the attending, is what do we do with the clothes? Is it something that can be washed, rinsed? Is there a leather issue about the organophosphate being, kept in the leather? And hopefully we have a good end.
Most people say that the clothes, you don't give them back.
Okay.
The whole thing. As far as the leather, we've even had cases of people that were spraying their yards and so forth, and they were wearing leather shoes, and they would re-expose themselves. So even 2 weeks later from their shoes. So it was a considerable spray that they were doing, but either way, I mean, most people will tell you if it's a leather product that they can't have it. I mean, that it just, you can't really reuse it.
The insect control people or service, it's never shocking that you see them walking around spraying everything without any protective gear.
Right.
And it could be a number of things they're using. And I'm wondering, is there any studies that ever were done to analyze or sample or take to see if there was any concentrations for how long of these people's shoes, leather? Are there any publications that are out there? I mean, I'm sure I could PubMed it.
I don't know. I don't know.
I don't know.
Is that for next year? Thank you.
Okay, thank you, Vicki, and thanks for audience for the questions. And I would like to announce our next speaker at this time. Our next speaker is Kim Shepard, and she is an RN, and she is at the IWK Regional Poison Center in Halifax, Nova Scotia.
the end of hers. Yeah, there we go. And there we go. Aha, there we did it. Okay, thank you for having me here today. I'll warn you too that this is my first time being here, so my voice tends to wobble because I forget to breathe when I talk. So bear with me. I'm going to present a case of pediatric opioid poisoning that came through our center earlier this year. So it was a 22-year-old female found unresponsive in the bed by her father. 911 was called. She was transported to the nearest emergency room by ground ambulance, a trip of about 50 kilometers or 30 miles. Suspected opioid exposure. Naloxone was given pre-hospital, an unknown dose and time, but there was no significant effect. So she arrived in the emergency room approximately 2 hours after the initial call to 911. A little bit febrile, tachycardic, no spontaneous respirations, so she was being bagged, unable to obtain a blood pressure. Pupils were non-reactive. Glasgow Coma Scale was 6, withdrawing to pain only. Glucose was low, as you see, and there was dry emesis visible on her nose, mouth, and eyes. Previously healthy child weighing about 15 kilos. So a question for the audience would be, what dose of naloxone would you recommend in this case? Okay. Okay, so about 50% went with 0.4 milligrams and about 34% with 2 milligrams. Those are the two highest. So I'm not going to discuss that right now because I'm going to throw this question over to the expert panel. What dose or doses of naloxone would you recommend?
Can I just, there's something here that appears to be missing to me, and I don't know why you think that this is an opioid exposure. The child is tachycardic, febrile. It's too early to have developed a pneumonitis from aspiration. I realize they're not breathing spontaneously, but they're hypoglycemic. How about a dose of sugar? That would be my dose of naloxone. I'm sorry.
Good point. Any other?
If you're looking for a specific dose of naloxone, it's a kid. If you're suspecting it's an adult strength medication, it's a competitive event. So, I mean, if it's an adult dose, of a medication, I would normally think that you would do an adult dose of naloxone to compete against it. The safety is fine.
That leads into the next question. Do you recommend different doses of naloxone in pediatric versus adult opioid exposures?
I think naloxone is a very safe drug.
And is there a maximum dose of naloxone you would use in peds?
Well, I would kind of step back and say, what are we dealing with this patient? Should we even be giving naloxone? I mean, the question is, we really should pay attention to what's going on with the patient. And what I'm concerned about is that this is a baby that's not breathing, that sounds like the baby's vomited and may have aspirated, and we may have to intubate. And why would you want to give an antagonist when you're going to have to sedate a baby? So it's not the answer to the question you asked.
Okay. Okay. I'll progress with the case. The baby did indeed get about 0.1 milligram per kilo of naloxone, so 1.5 milligrams. Was the dose that was given, repeated 3 times at 0.2 milligrams IV. She was intubated, still remained unresponsive, tachycardic, had a bolus of saline. Initial labs, probably no surprise, she was acidotic. Total CO2 was low, glucose again was low. After intubation, a few minutes later, they gave a paralytic. Not sure why there, but within a few minutes her heart rate did drop and CPR was required. So then she was resuscitated with atropine, epinephrine. There's some glucose finally. Another dose of naloxone, and the pediatrician was called to the emerge for the rest. She was resuscitated further with epinephrine. After about 15 minutes, they did detect a pulse, but no blood pressure that they could obtain. She was started on dopamine, given another 500 cc bolus of saline, given some bicarb for the acidosis. Felt at this time she had some pulmonary edema, so she was given Lasix and Ventolin. Interestingly enough, this was about 1 hour after arrival in emerge, there was a positive drug screen for methadone metabolite. So at this point, she's had several doses of naloxone with, say, little effect. However, now she's been sedated and chemically paralyzed. Would you start a continuous infusion of Narcan or naloxone at this time?
No, I don't. I think this is sort of a classic example of what Dr. Rumack used to say: treat the patient, not the poison. And as been described by the panelists, that there's this overriding need for naloxone, which is typically indicated for respiratory arrest, or depression rather, from an opioid. But this patient being bagged and subsequently intubated, there was really no need to continue to be concerned about naloxone. It's not gonna, and then she's getting all the fluid, the 500 cc's, and she's put on dopamine, whether the fluid's coming out, and she's got pulmonary edema or signs thereof, and there's been, so it's really more this, it seems like this should have been, that the focus, this is where we go wrong a lot of times. The focus needs to be on supportive care, and supportive care is very difficult to provide, and that's probably what this child really needed and didn't need any more. Maybe if you get a dose of naloxone in the field, doesn't work, could be a very low dose, because you'd have to deal with the amounts that the person ingested, and maybe you try one dose in the emergency department, but that's it. And if it doesn't work, boom, you're done, and you move on, and you balance the system and try to